Hi, I'm Dr. Alexander Balan and would like to discuss with you hydrocephalus in this video. Information is taken from NCBI article and you can access this information directly from attached link below the video. By definition, hydrocephalus is a symptomatic accumulation of cerebrospinal fluid or CSF inside the cerebral ventricles. This accumulation may be due to obstruction in the normal flow of the cerebrospinal fluid or to problems with absorption into the venous system by the arachnoid granulations or due to excessive production. In adults, there are 4 different types like obstructive, communicating, hypersecretory, and NPH or normal pressure hydrocephalus. Also, another classification is congenital or developmental hydrocephalus is often present at birth and is often part of a genetic syndrome or spinal dysrefuse. As introduction part, I can add that surgical treatment with ventricular shunt placement is the first treatment option, or endoscopic short ventriculostomy and choroid plexus catheterization are possible options in suitable form of hydrocephalus. It is an acute condition without prompt treatment can result in brain herniation and even death. Etiology: so obstructive hydrocephalus develops from a block of cerebrospinal fluid pathways. The obstruction most commonly occur at the foramina Monroe, the aqueduct of Sylvius, the fourth ventricle, and foramen magnum. But most tumors with a significant size can obstruct at any point of the cerebral spinal fluid pathways. Some of the most frequent tumors associated with hydrocephalus are ependymoma, subependymal giant cell astrocytoma, choroid plexus papilloma, craniopharyngioma, adenomas, gliomas, hamartomas, and even metastatic tumors. Important to know that posterior fossa tumors are commonly associated with the development of hydrocephalus, especially at the process of surgery. Pay attention for this. Communicating hydrocephalus. So this are attached to obstructive type of hydrocephalus. Communicating hydrocephalus is caused by impaired absorption of cerebrospinal fluid. The most common causes are post-hemorrhagic or post-inflammatory changes. Subarachnoid hemorrhage accounts for 1/3 of all the cases by blocking cerebrospinal fluid absorption at the arachnoid granulations. Also, meningitis as bacterial type can be complicated with hydrocephalus. Hypersecretory hydrocephalus is caused by an overproduction of cerebrospinal fluid, most likely due to plexus papilloma or rarely carcinoma. NPH or normal pressure hydrocephalus is a type of communicating hydrocephalus, and with a not fully understood pathogenesis. Impaired cerebrospinal fluid dynamics cause it with slight or no increase in intracranial pressure. 10% of all cases of hydrocephalus in newborns is due to brainstem malformations and stenosis of the cerebral aqueduct. Then the Walker malformation will cause 2 to 4% of hydrocephalus in this age group. Arnold-Chiari type 1 and type 2, agenesis of the foramen of Monroe, Vickers-Adams syndrome are common syndromes in newborns with hydrocephalus. Hydrocephalus is most common in infancy, secondary to congenital malformations and from intraventricular hemorrhage in premature babies. The overall global prevalence of hydrocephalus is approximately 85 per 1,000. African have a higher hydrocephalus prevalence. Pathophysiology. Cerebrospinal fluid is chiefly produced by the choroid plexus, which is located within the lateral third and fourth ventricles. So lateral, third, and fourth ventricle. Here they are located. It travels through the ventricular system from the lateral ventricle to the third ventricle, from lateral to the third ventricle via the foramen of Monro, from the third ventricle to the fourth ventricle via the aqueduct of Sylvius. It leaves the fourth ventricle through two lateral foramen of Luschka, as you see here. Foramen of Luschka, two of them, and median foramen of Magendie to enter the basal cistern. Through and part of it continues to flow around the spinal cord. For example, it will be spinal cord, and it's a space between the spinal cord and dura mater. So the main signs of cerebrospinal fluid absorption are arachnoid granulations that project into the dural venous sinuses, especially superior sagittal sinus. Superior sagittal sinus. Cerebrospinal fluid is absorbed into the venous sinuses and enters system circulation. The average cerebrospinal fluid volume is approximately 150 milliliter, and the daily production is about 500 milliliter, so 20 to 25 milliliter per hour. This means that the total cerebrospinal fluid volume is replaced 3 times per 24 hours. Cerebrospinal fluid flows slowly from sites of production to the sites of absorption. Any physical or functional obstruction within the ventricular system, subarachnoid space, or venous sinuses can be a reason for developing hydrocephalus. An obstructive lesion or gliosis can block cerebrospinal fluid flow within the ventricular system. Inflammation or scarring of subarachnoid space or elevated venous pressure within the venous sinuses can impair cerebrospinal fluid absorption into the systemic circulation. And the Monro-Kelly doctrine. According to this doctrine, the total volume of the brain, cerebrospinal fluid, and blood within the skull is constant, and an increase in one of the compartments must accompany a decrease in volume in another compartment. Otherwise, the pressure within the head will be increased, as happens in hydrocephalus. Increased intracranial pressure results in transepidermal extravasation of cerebrospinal fluid into the brain tissue, and causing brain damage and pressure-induced atrophy if it is a long-time process. Physical examination. Acute hydrocephalus is a life-threatening condition and can result in brain herniation, transtentorial herniation or temporal lobe or herniation of the cerebellum into the foramen magnum, with clinical picture of dilated and non-reactive ipsilateral pupil, autonomic dysfunction, and loss of brain stem reflex and coma. It requires immediate neurosurgical intervention to relieve the pressure. At birth, congenital hydrocephalus is usually present at birth. An unusually large head is a significant sign of congenital hydrocephalus. There are many more symptoms associated with congenital hydrocephalus, like tense or bulge, fontanelle, disjunction of sutures, thin and shiny scale with prominently visible veins, stiff arms and legs, prone to contraction, breathing difficulties, poor feeding, the unwillingness of the infant to bend or move their neck or head. Acquired hydrocephalus can occur at any age. Symptoms include headache, neck pain, nausea, explosive vomiting, drowsiness, lethargy, irritability, seizure, confusion, disorientation, blurred vision, diplopia, urinary and bowel incontinence, gait instability, balance problems, and lack of appetite, even personality changes and memory problems. Hakim triad of NPH or normal pressure hydrocephalus. There is even a mnemonic like white-based gait, dimension, and urinary incontinence that you should know. Evaluation or diagnosis of the hydrocephalus. Cerebrospinal fluid analysis could be done to help with the diagnosis and to exclude residual infection. X-ray of the skull may show erosions of the sella turcica or so-called Batten copper cranium. So this one is a X-ray of the patient with hydrocephalus, and on the right side with normal cerebrospinal fluid pressure. Ultrasonography through the anterior fontanelle may be used in infants for evaluating the ventricular system and progression of hydrocephalus. As you see here, a significant dilation or Mickey Mousers of right lateral ventricle. So they are a little bit increased in size. Neuroimaging or emergency CT scan of the head may be used in infants and in adults and play a central role in confirming the diagnosis in suspected cases. This one is CT, and you see dilated cisterns or lateral ventricles. MRI or magnetic resonance of the brain is a study of choice as it shows better the posterior fossa structures and can differentiate between brain tumors and degenerative diseases, and can differentiate normal pressure hydrocephalus from cerebral atrophy. Once again, I gave normal pressure hydrocephalus as example, and on the left side you see normal MRI scan of the brain. So transepididymal exudate can be visualized as periventricular hyperintensity on T2 or flare sequences. Cerebrospinal fluid extravasation must be differentiated from age-related changes of periventricular white matter. In cases of chronic hydrocephalus, temporal horns may not be so prominent. Corpus callosum may be atrophied in these cases as well, but the neurodegenerative disease should be excluded by MRI. And the last line is radionuclide cisternography, which has low sensitivity and is not commonly used as test of diagnosis. Treatment: hydrocephalus, if left untreated, can cause permanent brain damage, physical and mental impairment, and even death. Treatment is directed to the etiology. In cases of intraparenchymal hemorrhage or tumors, surgical evaluation may resolve the hydrocephalus. When hydrocephalus persists, treatment is surgical with the insertion of the ventricular shunt. The shunt moves cerebrospinal fluid to another part of the body where it can be absorbed. Ventricular peritoneal shunt is the most common type of shunt. It usually drains cerebrospinal fluid from the lateral ventricle to the peritoneal cavity. And the goal is to be absorbed this cerebrospinal fluid, which is rich in many components for brain nutrition especially. The other common type is the ventriculoatrial shunt. It shunts cerebrospinal fluid through the jugular vein and superior vena cava into the right atrium. It's mostly used in patients with abdominal abnormalities like peritonitis, after extensive abdominal surgery or morbid obesity. But it have one minus, as patients with increased jugular vein pressure can make stoppage or a decreased absorption or drainage to the heart from the ventricle. There are alternatives of shunting that may be considered. Endoscopic third ventriculostomy opens the floor of the third ventricle to permit the cerebrospinal fluid in the third ventricle to enter the prepontine basal cistern. Endoscopic third ventriculostomy is commonly used in cases of aqueductal stenosis to prevent a permanent shunt. However, the result in very young infants is not good. Choroid plexus coagulation can be used for cases of overproduction of cerebrospinal fluid, or repeated lumbar punctures can be done in cases of communicating hydrocephalus if it's considered that spontaneous resorption is likely to occur. Acute hydrocephalus is a medical emergency for those cases where a shunt cannot be placed urgently, and anterior fontanelle ventricular tap may be performed in infants. In adults and children, placement of external ventricular drain is the most common procedure performed in these cases. Lumbar puncture in post-hemorrhagic and post-meningitic hydrocephalus is an option. To know that the majority of patients with a posterior fossa tumor who present with hydrocephalus do not require a permanent shunt. A ventriculostomy may be placed temporarily preoperative or intraoperative to help for the tumor resection and remove it when not needed. Acetazolamide, a carbonic anhydrase inhibitor, I have to add at this slide, decreases cerebrospinal fluid secretion by choroid plexus and hence used in treatment of hydrocephalus. It is mostly used in pseudotumor cerebri. Thank you very much for your attention. Hope this video helped you in understanding the hydrocephalus. Have a good time.